Chapter 4, Learning Clinical Communication Skills. Overview. This chapter will give you a general introduction to clinical communication. Skills, e.g., the communication skills you will be developing as a medical student and as a doctor. We will look at what they really are, the reasons for learning them, how to learn them at medical school and in the clinical environment. Introduction. As a medical student, you have already shown that you are good at communicating with others by successfully passing exams, completing a UCAS application, and possibly undergoing interviews for medical school or maybe a job. The good news about clinical communication skills is that they can be learned and build upon the skills you already have. They build upon the interpersonal skills, which are the general skills you use when communicating with others, such as starting and taking part in a conversation or using and reading body language, etc. Interpersonal skills are important in your communication as a medical student or doctor, and you will be building on these to develop the specialized and higher order clinical communication skills you will use as a doctor. So don't worry too much if communication seems a challenge at the moment. With time and practice, it will become clearer. Clinical communication skills will become an important part of the clinical skills toolkit you will develop over the next few years. As during your life as a doctor, you will probably conduct between 120 and 160 medical interviews with patients. Why learn clinical communication skills? Clinical communication skills are the language of medicine and the medium by which medicine is practiced. They are not only essential in communicating with patients but also with colleagues, other members of the healthcare team, and the wider community. At the heart of all clinical communication is the medical interview and the relationship that is built during this between doctor, student, and patient. This fundamental relationship is so important and powerful that it can enhance or inhibit the patient's well-being and ability to adhere to treatment. Some would argue that this relationship is therapeutic in itself and an essential component of any treatment of a patient. Competent clinical communication skills are therefore important in providing the best possible care for patients and in enhancing your practice and satisfaction as a clinician. Sometimes students think the aim of clinical communication skills is to be kind or nice to patients. This is not the main aim at all, as we shall see. Think rather that effective use of clinical communication skills will bring about an empathic, effective, efficient, and satisfying interview for all concerned. But we do, of course, hope that kindness and politeness will always be at the center of your professional practice as a student and as a doctor. I thought communication skills classes were a waste of time, as I've always been good at talking to people and had lots of experience with my previous job. I found though that they were about something different, proper professional communication. Someone told me clinical language is the equivalent of learning French. Marshall, first year graduate student. Clinical communication skills are evidence based, and it is through extensive research that we know that the physical and psychological health of patients are affected by clinical communication and that they play an important part in most litigation or complaints brought against doctors. They are therefore constructed from an evidence base that is as scientific as any other part of your clinical course, and in some cases is more so. When thinking about why we learn clinical communication skills, it may be helpful to look at some important recommendations made by the General Medical Council as part of the Tomorrow's Doctors document, which contains recommendations for undergraduate medical education. The GMC states that medical graduates must be able to communicate clearly, sensitively, and effectively with patients, and their relatives and colleagues from a variety of health and social care professions, and that the curriculum must stress the importance of communication skills and the other essential skills of medical practice. Also, as part of the duties of a doctor registered with the GMC, doctors must treat every patient politely and considerately, respect patients' dignity and privacy, listen to patients and respect their views, give patients information in a way they can understand, respect the rights of patients to be fully involved in decisions about their care, and so the GMC supports the learning and importance of clinical communication, skills, and the rights of patients to be respected and treated with dignity. At the beginning of your learning as a medical student, it will be important to think about the kind of doctor you want to become and explore some of the philosophical and ethical positions around this, developing and exploring humanistic views that value the dignity and worth of all people will provide a good foundation for building clinical communication skills. A humanist approach encourages the medical student doctor to walk alongside the patient, acting as an expert guide but also facilitating the patient to make the best choices for themselves. We know that during the medical interview, the patient history that is elicited by the doctor accounts for 60-80% of the diagnosis more than the physical examination or any investigations. So being able to conduct a competent medical interview and elicit a patient history are essential clinical skills. Importantly for you as a medical student, clinical communication forms a core part of the curriculum of most medical schools in the UK and will be assessed throughout your undergraduate and postgraduate studies. They are as important as any other clinical skill and will demand your time and effort. Assessing yourself and others. You probably know quite a lot about general communication already. As a starting point in thinking about your own skills, fill in this communication. Self-assessment exercise. We all need to develop self-appraisal skills if we want to have insight into our own progress and learning needs. Look at the self-appraisal questionnaire below to consider where your strengths and weaknesses lie. Skills inventory. Think about yourself in this scheme. On a scale from 1 to 10, how good are you at listening? Really listening? Do people generally feel comfortable with you? How good are you at trying to put yourself in someone else's shoes? How comfortable are you with silence? How able are you to listen to people's feelings about their problems? How able are you to listen to people's feelings about their distress? How able are you to listen to people's feelings about their anger? How good are you at explaining things to people? How good are you at recounting events or telling stories? Could you summarize clearly and accurately something you have just heard or read? Are you able to tell someone honestly what you think when you know the truth? May offend, upset, or hurt them? Are you able to negotiate options when there is disagreement? Now think about these three questions. 1. Consider what these answers might tell you about your strengths and weaknesses. 2. How do you know the answers you have given are correct? 3. If you dare, ask someone else that you trust to be honest to fill it out for you. Now you have a basis for thinking about your own communication skills and what your strengths and weaknesses are. The important thing is to work on the weaknesses as we would all rather practice the communication skills we are good at. Another helpful exercise to spotlight effective communication skills is to think about a personal problem you have had in the past. Was it difficult to talk about? Who did you talk to about it? Why did you choose that person? What was it about them that helped you to talk? Can you describe the specific behaviors they used? You may come up with a range of answers such as, the person was a good listener, didn't interrupt and remembered what you told them. You could trust this person not to gossip because you know they are discreet and never repeat private things. The person didn't judge you or your actions. The person was able to give you an honest opinion or advice. The attitudes and skills that you identify that help you talk about your own problems usually apply to patients who want a doctor who listens well, doesn't interrupt, remembers the things they say but keeps them confidential, and is honest and non judgmental. We can transfer the communication skills that help us to our conversations with patients. My favorite celeb has always been Gordon Ramsay for his straight talking. When I analyzed his communication style, though I decided he wouldn't make a good doctor, sheep, first year student. What are clinical communication skills? Clinical communication skills cover a wide range of skills, but at a basic level, concern themselves with eliciting a patient history, explaining, exploring, discussing informed consent, breaking news, negotiating, passing on accurate information to colleagues, presenting a case history to colleagues. As an illustration, let's think about a medical interview and break down the clinical communication skills under rough headings. A checklist of communication skills, introduction and orientation, welcoming manner, gives name and role, explains purpose of the interview and any note, taking, confirms patient's comfort, agreement, rapport, shows interest, respect and concern, appropriate body language, matches language and energy levels, listening skills, listens attentively without inappropriately interrupting, responds to patient's answers, picks up on patient's cues, questioning skills, appropriate blend of open and closed questions, clear jargon-free questions, clarifies when necessary, avoids leading questions, keeps note-taking appropriate, empathic responses, reflecting back and acknowledging patients, feelings and concerns as expressed in the interview, information giving and explaining, checks what patient knows, understands, gives clear jargon-free explanations, well-paced, invites questions, checks patient's understanding, draws, uses diagrams where appropriate, respecting autonomy, negotiating and shared decision making, proposes options, their benefits and risks and helps the patient make their own decision, refrains from judgment, threats or irritation, appropriate reassurance, handles uncertainty appropriately, refrains from false or premature reassurance, offers appropriate reassurance or help. Closure summarizes main points to ensure everything is covered and information has been gathered accurately. If applicable, explain next step. Organization of the interview, summarizing, signposting, systematic and logical flow. This checklist shows the main process headings of a medical interview and breaks these down into skills. The content of the interview is the information that is gathered or given. So we may say that some clinical communication skills are the process skills that enable the content to be gathered essentially. You can't have one without the other. The thing to know about good clinical communication skills is that they help to build the relationship between the student, doctor, and the patient. Without this, any medical encounter will be poor and lacking in satisfaction. For both parties, an important part of building this relationship and one of the essential principles you will learn as a medical student is the basic humanity and power of empathy. Empathy is the ability to walk a mile in the patient's shoes or the appreciation, understanding, and acceptance of someone else's emotional situation and is different from sympathy, which is about feeling sorry for someone. Empathy can be expressed in many ways and is the foundation of a patient centered approach to care, exploring and Trying to genuinely understand what is going on in a patient's life provides a greater depth of understanding of their situation, builds a strong relationship, and aids diagnosis and treatment. How are clinical communication skills learned? You are already reading about clinical communication skills, and this is a good place to start. At the end of this chapter are some references for books that will help you look further at some of the theories and models of communication. If you are interested, however, clinical communication skills cannot be learned entirely from books and must be learned by practicing or doing them. This is sometimes called experiential learning and may be different from some of the learning you have done in the past. Experiential learning encourages you to actively try things out in a practical way and learn from the results. It encourages you to build upon the experience you already have and use this as a basis for developing new knowledge and skills. Think about this. Next activity as an example. Exercise an example of experiential learning. In order to practice your information gathering skills, you decide to interview a friend about his recent trip to the GP surgery for a sore throat. You talk to him for about half an hour, asking questions and gathering details of his story. You might write some of this down in order to practice taking notes. At the end of the interview, you ask your friend for some feedback about how the interview went and how he thinks you did. He tells you that you made him feel comfortable at the start of the interview by looking interested in what he was saying. He says that you were very clear that the reason for the interview was for you to practice gathering information and that you asked clear and straightforward questions. He also tells you that he would have liked to tell you how frustrating it was to wait 45 minutes to see their GP and how apprehensive he felt when the GP took a throat swab, which actually made him want to vomit, but he didn't feel he could interrupt your flow of questions, and as you were looking down to take notes, he couldn't catch your eye to interrupt. On the way home, you think about and reflect on the interview. You realize that you were successful in gathering information from your friend, but that you got so carried away with asking him your questions and taking notes that you didn't give him an opportunity to tell you about the things that were important for him. You decide that next time you interview someone, you will start by asking them to tell their story first before asking your questions, and so start with what is most important for them. You also decide to spend less time looking down at your notes and more time maintaining eye contact to pick up body language clues. Using role play to learn clinical communication skills. Many medical schools use role play as part of experiential learning. Role play allows you to try out or practice a patient interview in a simulated setting with a simulated patient and actor, another student, or sometimes a specially trained patient. A role play group should be thought of as a safe laboratory for experimenting where any explosions will be harmless. And so don't be afraid to try things out, experiment, and see what works best for you, as this is a golden opportunity and there is no such thing as a perfect role play. We all have different ways of learning, and some people may feel less comfortable about learning with role play, but just resolve to give it a go, jump in at the deep end, and see how it feels. Many people who feel apprehensive at the start go on to really enjoy and value role play as an effective way of learning clinical communication skills. In fact, all the research tells us that experiential learning and role play are the best ways to learn clinical communication skills, and that it is important to practice these skills as much as possible. As we've already mentioned, it takes 10,000 hours of deliberate, reflective practice to become an expert, and at least 100 hours until you become reasonably competent at a skill. Clinical communication skills are no different, and so Practice, practice, practice makes perfect. The usual setup is for a role play session to be carried out in a small group. With a tutor, there is usually a predetermined patient scenario that has been written to allow particular skills in a relevant clinical situation to be practiced. In its simplest form, each student tries out a role with an actor or simulated patient for a short time and then gets feedback on their performance from others in the group. Sometimes there is an opportunity to redo parts of a role play to see if things turn out differently, and sometimes the role play can be recorded on video or DVD to allow the role player to see themselves in a particular situation. Seeing yourself on video can be a nerve-wracking experience the first time, but students rate this highly as a very useful learning experience. You often have to play the video DVD several times until you get over seeing and hearing yourself on screen and can look at what is actually happening in the role play. Feedback is an essential part of role play. In fact, you cannot have one without the other. We all need feedback from others to get a different perspective on our performance, and just as we saw in the experiential learning example, often we are not aware of some of our own behaviors and how others may see or be affected by these. Giving and receiving feedback should be an honest and constructive experience. Feedback is not about character assassination or comments of a personal nature, but should be focused on a person's behavior in a given situation, helping them to develop new perspectives or behaviors if appropriate. An example of this may be that you have watched a fellow student talking to a patient and noticed that the patient was finding it difficult to hear because the student was speaking so softly. The feedback you may want to give would be centered on the student speaking louder and also watching the patient too. Pick up cues that they found it difficult to hear. This feedback could allow the student to think about their behavior next time and possibly change it. What you would not give feedback on is the student's voice itself, which is personal, probably can't be changed, and will result in them feeling hurt or personally criticized. Behaviors and skills are not in themselves good or bad. It depends on the effect they have and if they are achieving the objectives. When giving someone feedback, remind yourself to look at what worked well at the same time as what might be improved and consider suggestions for how to improve things. This is important for a reason other than kindness, as at any given moment we can only put a certain amount of energy toward changing ourselves. It is a help to know what we already do that works well and therefore doesn't need to be looked at. We can then concentrate more easily on other suggestions for change. Some feedback tips. Do whenever possible allow the person whose skills are being evaluated to do a self-critique first. Usually, people in this position are very critical and find it difficult to describe what they have done well. Although they may need to deal with any problem they experienced, it is also important to point out aspects that worked well. When you give feedback, you may find that all you have to do is emphasize points already made by the person whose skills are being discussed. If not, make 2 or 3 comments, but always by describing what you saw, why you think it is not the best way, and what you suggest would be an improvement. Try to make it a habit to write down some of your comments so that the person can read them later. Do always focus on what you see by describing behaviors. For example, rather than saying something general like you're doing okay, try something specific like I like the way you checked to make sure Mrs. Jones understood your explanation. There is a difference between the intention behind our behaviors and the effect they have. For example, rather than say you made that patient embarrassed, try something like I thought the patient looked embarrassed. Remember that all feedback is subjective and the person receiving it may disagree. So it is important to be specific when giving feedback. Concentrate on a particular part of an interview and perhaps write down some of the words that are said This will aid your memory. It is also important not to overwhelm people with lots of feedback that they probably won't remember. Try to limit feedback to the three most important things you saw. When I saw myself on DVD doing a role play, I couldn't believe how awful I looked and sounded. I had to go over it with friends lots of times. Eventually, I could see what I was doing, and it was really helpful to have that perspective. Feedback, third year student. Feedback can be a tricky skill to get right and needs practice. We all enjoy giving positive feedback but find negative feedback more difficult. Interestingly, students say they value honest feedback from colleagues and teachers above all else and find it the most helpful way to learn. Working in small groups with colleagues allows you to develop an honest and trusting group relationship that fosters constructive and honest feedback. Giving and receiving feedback will be important skills to develop over your medical training, as they will not just be needed for role play but for a range of things throughout the rest of your professional life. Someone who regularly gives and receives feedback will be in tune with others and not just relying on their own thoughts and opinions. Learning clinical communication skills in the clinical environment. At some point in your course, you will begin to learn and take part in the clinical environments of hospital wards, outpatient clinics, and general practice and primary care. For some people, this will be the most exciting and rewarding part of their course, and for others, it may seem quite unstructured and therefore a little daunting. The work you may have done experientially will be a good preparation and foundation for this part of the course where you will be talking to and learning from real patients. The clinical environment offers wonderful learning opportunities, but sometimes it is difficult to recognize them, particularly if you are the kind of person who likes very structured activities with a tutor taking the lead. We remember our own experiences of going onto a ward for the first time and not knowing where to physically be for most of the time. Everyone seemed to be very busy, very confident, and knew what they were doing. It took a few weeks to settle in and find our places in this new world. Everyone feels like this. The vital thing is to realize that you have to make learning opportunities for yourself, as clinicians will have competing priorities and won't be able to offer support all the time. It may be helpful to plan your day around the structures that already exist, such as ward rounds, surgeries, and clinics. Ask yourself, how can I prepare for the upcoming ward round, surgery, clinic? Which patients should I be talking to and examining today? How will I get feedback on what I am doing today? How will I record what I have learned today? Which other members of the healthcare team should I be working with today? At this point, it is important to mention informed consent and patient rights. You will remember that these were more fully written about in the clinical skills section. In the clinical environment, you will be introduced to clerking, which is taking a full history and performing a full examination of a patient. At first, this will take quite a while and you will need lots of practice. Aim to fully clerk 5 patients per week, and this will soon add up to a substantial number. Remember, each skill takes 100 hours of practice in order to achieve a minimal competency. By interviewing patients regularly, you will learn how to approach them and build rapport, how to find out about their story and record this accurately, how to elicit their concerns and fears and find out about their health beliefs, and how to examine them competently. The more you talk to patients and immerse yourself in the clinical environment, the easier things will become. If you are the kind of person who finds it difficult to approach a patient or strike up a conversation, try to prepare for this in advance by visualizing what you will do. Visualize yourself walking over to the patient. Visualize how you will greet them. What words will you use? How will you go through the steps of consent? What words will you use? Will you ask for permission to sit down? What opening line will you start off with? The weather, their journey. Photos on the locker asking about lunch. This technique is useful for preparing yourself. It may also be helpful to jot down the areas you would like to talk to them about on your pad to act as an aid memoir. A simple history template is sometimes helpful. The presenting problem. History of the presenting problem. Past medical history, family history, medication history, social history, review of systems. A tip here is not to prepare the questions you are going to ask, but simply to be curious about your patient and their story and really listen to what they tell you. Often students stop listening and miss information because they are concentrating on the next question they are going to ask. Listening is one of the most important clinical communication skills. You also should avoid asking checklist questions guided by the history template. Patients do not tell their story according to a checklist. Your job is to map their story onto a clinical template rather than the other way around. Figure 4.1 The Calgary-Cambridge Guide, a guide to the medical interview. Initiating the session. Preparation. Establishing initial rapport. Identifying the reason for the consultation. Gathering information. Exploration of the patient's problem to discover the biomedical perspective, the essential background history, and the patient's perspective. Physical examination, explanation and planning, providing the correct amount and type of information, aiding accurate recall and understanding, achieving a shared understanding, incorporating the patient's illness framework, planning shared decision making, providing structure, summary, signposting, sequencing, timing, building the relationship, non-verbal behavior, developing rapport, involving the patient, closing the session. This is a good point to introduce you to two models for taking a patient history. Model 1 is a simplified version of the Calgary-Cambridge Guide, which breaks the medical interview down into the 5 steps: initiating the session, gathering information, the physical examination, explanation and planning, and closing the session. At the same time, it provides 2 pillars that run through the 5 steps and outline the skills that provide structure for the interview and build the relationship with the patient. You may want to use this as a template for your interviews with patients. Model 2 is the patient-centered clinical interview, which presents the doctor's agenda and the patient's agenda as 2 parallel frameworks that aim to be integrated at the end of the medical interview. Again, the communication or process skills are made clear. These 2 models will provide you with a firm foundation for taking a patient history, and you may like to experiment using both to see how they fit with your particular interviewing style. Figure 4.2 Patient-Centered Clinical Interview. Patient presents unwell. Parallel search of 2 content frameworks. Process skills, attentive listening. Question style, open to closed. Clarification, summarizing, rapport, verbal and non-verbal. Content, disease framework, history, physical examination investigations. Content, illness framework, ideas, expectations, feelings, differential diagnosis, understanding the patient, integration, problem-oriented medical record, management plan. Where possible and appropriate, try to interview patients in pairs initially. This allows one of you to talk to the patient while the other observes and gives feedback. If you are feeling really brave, you could also ask the patient to give you some feedback. Remember that feedback is the key to good clinical communication skills, and that the more you receive, the better and more skilled you become. Try to get feedback from a variety of people so that you get a wide perspective on your skills. It will be important to ask the senior doctors and nurses to watch you for a few minutes with a patient and then give you feedback. You may like to ask them for specific feedback For example, supposing you have identified that you have a tendency to inappropriately interrupt patients before they have finished telling you something, or that you find it difficult to use open questions when taking a patient history, ask for specific feedback about these. It can be really helpful to pinpoint specific things. But you must also bear in mind that our feedback is subjective and opinion based, which is why gathering a variety of views helps to maintain a balance. One of my interviews in the third year was with a patient who cried when we talked about his wife who had recently died. I felt useless at the time. But the next day when I went back, he said he was comforted by me just listening to him and thought I would make a good Dr. Munat, fourth year student. Not all interviews with patients need be long or very formal. In some settings, such as outpatient clinics or GP surgeries, it may only be possible to speak to patients for a short time. Gathering and grabbing all opportunities to talk to patients is the vital thing and will help you build up an extensive and varied experience base. A useful tip is to keep a patient interview diary where you write down the various interviews you conduct, what were the strengths and weaknesses and what you have learned from these and what to try out next. It may also be helpful to record the particular types of histories or examinations you have done to make sure you have a wide experience. For example, if you have spent some time interviewing patients about their asthma, perhaps you should aim to do the same with patients who have diabetes or are about to undergo a procedure or operation of some kind. This way you have a clinical log as well as a reflective journal of clinical communication skills. Summary: in this section we have looked at the definition of clinical communication skills, why they are used and how they can be developed and practiced in a simulated setting. We have looked at ways of applying them in a clinical environment with real patients and at the importance of feedback to their development. We have looked also at the doctor-student-patient relationship and the importance of empathy to this. Clinical communication skills are not about being kind or nice to patients. Good clinical communication is essential to clinical competence. Clinical communication skills are evidence-based. Listening and curiosity are key communication skills. Practice and feedback are essential to the development of competent clinical communication skills. Questions and answers. Q. I find it difficult to disturb patients to talk to them as I cannot help with their treatment. A. It is quite true that talking to patients is for the purpose of helping your learning and education. But patients quite often enjoy talking to students and may feel this is a way of practically helping with your education. It is also true that you have a right to be a learner and that although the needs of the patient must be uppermost, the best way for you to learn is by talking and practicing. Q. I find the words quite bewildering. I never know which patients to talk to or whether it is okay for me to talk to them. Everyone feels like this at the beginning. The important thing is to agree with your clinical supervisor which patients you will approach as she will be able to guide you and may want you to look at specific patients. Perhaps because there is a ward round coming up or because the patient is about to return home, etc. The vital thing is to treat the clinical environment as a place of learning and try to gain as much experience as possible. Q. A patient that I particularly got on with told me something she had not told the doctor. A. This sometimes happens, which is why it is important that when you obtain consent to interview a patient that you explain you cannot guarantee confidentiality between you, but that any information will be shared within the healthcare team. Importantly, though, it will not be shared outside the healthcare team, which includes the patient's family, friends or work, etc. You will need to discuss any additional information you gather about a patient with their supervising clinician. Q. It takes me a long time to take a patient history, sometimes over an hour. Nobody else seems to take this long. A. At the beginning, it is common to take a long time to interview a patient. Over time, you will become more comfortable with the process and more proficient at interviewing or examining a patient. Enjoy this time and make the most of being with patients in an unpressured time frame. Q. Sometimes it feels like I am prying into the patient's private life when I take a history. A. This is a common and understandable concern, but there is a clinical reason for asking a patient personal questions. In the normal run of things, a patient would not dream of sharing such information with you. But as a medical student, you are in a privileged position in which you are able to ask patients in-depth questions about their lives. You seek out this information in order to take a full and competent clinical history. It is not done as part of curiosity or prying, but as a clinical skill.